update on IgA nephropathy. I'm Dr. Padmini, nephrologist from Kolkata, and will be your host tonight. IgA nephropathy was first described in 1968, and since then, our knowledge and understanding of the disease has changed by leaps and bounds. However, there are still many unresolved issues pertaining to its pathogenesis, treatment. In the next 1 hour or so, we'll be discussing on what's new in IgA nephropathy. So quickly, we move to the first session of the evening. That's epidemiology of Indian IgA. Is it different from the West? It would be presented by Dr. Sakina Alexander. The session would be chaired by Dr. YJ Anupama. She's a consultant nephrologist at Nanjappa Hospital, Shillong, and Dr. Santosh Varghese, professor and head of the Department of Nephrology, CMC Vellore. And indeed, we know him as an astute clinician and a commendable guide. So over to you, Anupama ma'am, to carry forward the session.
Anupama, you are muted. Anupama, you are muted.
Okay. Can you hear me now?
Yes, ma'am, we can hear you.
Yeah. Okay. Thank you. And it's a great pleasure to be beginning today's update on IgA nephropathy webinar. And as we all know, IgA nephropathy is the most common glomerulonephritis in the world today, and especially in the South and East Asian countries. And the prevalence varies from country to country, but still it's more common in the East Asian countries as well as in India. And to be discussing about the epidemiology of IgA nephropathy in India, we have Dr. Susina Alexander here. She's a professor of nephrology at CMC Vellore, and she will be presenting her experiences since she has done a longitudinal study on IgA nephropathy, and she will be speaking on the epidemiology of IgA nephropathy in India. Dr. Santosh, would you like to introduce Dr. Susina Alexander?
Yeah, Susina is my colleague in the department, and I had the pleasure and privilege of watching her do the research all these years. So I think without much ado, we invite her to do the honors and start her presentation.
Good evening, and I thank the organizers for this invitation and the kind introduction, and all glory to Jesus. So the presentation, the 15-minute presentation is an epidemiology of Indian IgA nephropathy. Is it different from the West? It's a 15-minute talk. So the disclosure, I have a short disclosure, which is this has been presented in different versions in multiple forums recently. So I think some of you, at least in the audience, would have listened to many of these slides. The other disclosure is because of the want of time. If we go past 15 minutes, and I will be skipping some slides. Now, throughout the presentation, there are some questions that we need to keep in mind as we listen to the talk, which is it a different disease or the same disease with effect modifiers? Can the severity be fully attributed to late presentation? And what are the effect modifiers that we can hypothesize in the pathobiology of South Asian IgA nephropathy? Some of the challenges that are very specific to our region is the skewed doctor-patient ratio, no universal programs, no GPO reference system, a lot of indigenous and non-allopathic practices, and no uniform GN registries. So this cohort was built up back in 2015. It is called the GRACE IgA nephropathy cohort, with specific inclusion and exclusion criteria and longitudinal follow-up with biosample collection. We reached a target size of 201 individuals by September 2017. And by 2020, we had completed 3-year longitudinal follow-up, and the follow-up is still ongoing along with biosample collection. I would like you to know that this is a cohort which has specific inclusion and exclusion criteria. So you will have to take account of this when you generalize it to the entire IgAN population. Here, we did exclude patients who come to us with a GFR of less than 10 at presentation, and we had to make sure that they are immunosuppression naive, at least for 3 months prior to recruitment, because it included biomarker evaluation. And it was kidney biopsy proven primary IgA nephropathy in adults. Now, as you can see from the various regions of India, we have a fairly good representation from the south, central, and central east parts of India, as well as the neighboring countries of Bangladesh, Nepal, and Bhutan. This was a cohort distribution whereby you can see that I have divided the cohort into 3 tertiles, and all 3 tertiles were equally represented in the cohort, the eGFR tertiles. And within each tertile, we divided the cohort into the urine protein categories, and these are the representations. So the colors are coded by the symptom presentation at biopsy. And as you can see, the most of them are pink or red, which means that the most common presentation was hypertension, either alone or with pedal edema or other systemic symptoms. The macroscopic hematuria, which is the blue or the ash ones, are fairly insignificant in our cohort, and they are mostly seen in higher GFRs, that is more than 60 ml, as well as in higher proteinuria. So as unlike the West or the East Asian population, macroscopic hematuria was not a very common presentation, but hypertension, especially when young individuals presented to doctors with vision disturbance and hypertension was picked up secondary to visual disturbance, was a significant number in our cohort. This highlights the fact that there is a role for simple screening tests like urine dipstick for effective public health strategy. Now, coming to the time for a renal biopsy from the onset of symptoms, most of them, the median time for renal biopsy was around 4 to 5 months from the first symptom onset. The longest, I would say, was for hypertension, which had a median of 10 months from the onset of hypertension. Which again says that there is a smoldering subclinical IgA nephropathy in South Asian patients before they present to us symptomatically. The baseline laboratory parameters are presented here. Again, we had significant amount of proteinuria in the cohort. The serum creatinine, the mean value was 2.1, and the median eGFR with interquartile ranges was 36. I have highlighted the albumin because though it was, there was no severe hypoalbuminemia in our cohort, even moderate or mild hypoalbuminemia had significant effect on the clinical outcomes. Coming to the MEST-C score, we had quite a good number which had inflammatory lesions, but more than that, there was a good amount of significant majority of the cohort had sclerosing or tubular atrophy lesions. The C lesions were less, mainly because our inclusion criteria excluded RPGNs and severe renal failures. There was significant amount of people who had global glomerulosclerosis. This is a slide which shows a correlation of the MEST-S score as well as the T score with clinical or laboratory parameters, which are mean arterial pressure, 24-hour urine protein, and eGFR. And it shows a correlation between the S categories and the different T categories with the clinical parameters. Again, when we categorized it with the eGFR or the proteinuria tertiles, we were surprised to find that even in incidentally detected mild IgAN, there was significant amount of sclerotic lesions. Even at a GFR of more than 60 ml, as well as a proteinuria of less than 1 gram, we had an S1 lesion, which was about 19%, and a T1 but T2 lesion, which was 19%, and S1 lesion, which was about 40%. In the group that presented with macroscopic hematuria and hence presented at an earlier stage of the disease, again, the T1 but T2 lesions were found in 11 out of 18 patients, and the S1 was found in 13 out of 18 patients. This brings us to the next question, which is an open question as to whether it is a low nephron number, which is attributable to this, or whether it is a specific fibrotic response to mesangial IgA deposition. This is an observational cohort study. It is in no way a randomized controlled trial. It used the standard of care that we have in our center, which is we give alternate day steroids for 3 months and taper and stop it at 6 months if there is proteinuria more than 1 gram and the eGFR is less than 60 ml, along with maximally tolerated RAS blockers. So about 70% of our cohort got a short course of immunosuppression. The outcome at 3 years, there were 50% cumulatively who had partial remission, 28 who had partial remission of proteinuria was again defined as a 50% reduction in proteinuria to less than 3 grams if the baseline was more than 3.5, or to less than 1.5 grams if the baseline was less than 3.5 grams. Complete remission was proteinuria less than 300 milligram and both sustained over 3 months. Rapid progression was defined as an eGFR decline of more than 5 ml per minute per year. And composite outcome was defined as more than 50% reduction in GFR or end-stage kidney disease or the need for any renal replacement therapy or death, which was found in 37% of patients. Again, coming back to the diagram, which has divided the cohort into eGFR tertiles as well as the UPCR categories. The red dots are the ones that have had the bad outcomes, and the green dots are the ones that have had good outcomes at the end of 3 years. And you can see that it's fairly distributed across eGFR as well as eGFR categories. And there is significant worsening of clinical outcome in those who had sustained proteinuria. So a higher baseline proteinuria for any given eGFR level was associated with rapid progression or complete adverse clinical outcome. This is a graph which again shows the relationship of annual decline in eGFR with composite outcome. Again, we looked at the different rates, less than 0 to 5, more than 5 to 10 ml per minute per year decline, or more than 10 ml. And we found that, as shown in the right side, we found that a GFR decline of more than 5 ml had 86% sensitivity and 89% specificity to detect composite outcome at the end of 3 years, especially when it was recorded at a longitudinal follow-up of 1 year. So annual fall in eGFR of more than 5 ml significantly predicted composite outcome and had significant sensitivity and specificity in the ROC curve. Coming to proteinuria, the graph on the left side shows partial remission as well as complete remission in the good outcome group as well as in the bad outcome group. As you can see, in the bad outcome group, the remission rates, either complete or partial, were lower compared to the good outcome groups. And the level of proteinuria had significant influence on the clinical outcome, with more than 1 gram, which is shown as the green and the blue bars on the left side, left bottom, had sustained proteinuria of more than 1 gram, had significant worse clinical outcomes. And this is a longitudinal representation of protein, 24-hour urine protein over the 3 years, where you should remember that most of our patients had received a short course of steroids. So you can see that there is an RASB, which was to maintain a blood pressure, which was optimal. So with that, we got a significant reduction in proteinuria at 6 months. But after that, in the good outcome group, which is shown in green, though it remained low, in the bad outcome group, which is represented by the red figure, it was much higher than the good outcome group, and it continued to increase. This is the same thing that I have reiterated before, that time taken to achieve proteinuria has a significant impact on clinical outcome, and sustained reduction in proteinuria is a good factor. Now, coming to albuminuria, this is a slide which shows that even moderate to mild albuminuria has a significant impact on clinical outcome. You can see green is a good outcome group and red is a bad outcome group. And there is a significant difference in albuminuria longitudinally, even at baseline and at every follow-up time point. So serum albumin less than 4 grams had a significant impact. Some of the insights, I will go faster in these few sets of slides because I think we are running out of time. Insights into the pathobiology, we had measured secretory IgA, and it was found to be higher in the IgA nephropathy patients compared to healthy controls, but it did not correlate with any baseline parameters or any longitudinal outcomes. Coming to complements in South Asian IgA nephropathy, serum C3, there was lower, what I mean by lower serum C3 is lower range of normal. It is not low as in other glomerular diseases. Lower serum C3 was associated significantly with composite outcome, but was not a predictor in the multivariable Cox proportional hazards model. Higher serum C3 also was significantly associated, but there was no relationship in the Cox proportional hazards model. Mesangial C3 deposition did not have any associations with longitudinal outcome. We did stain for C4D in renal tissue, and tissue C4D staining was increased in IgA patients compared to disease control, but again, it did not it was not an independent risk factor in the multivariable model. The same thing goes for tissue C3D, which was increased in patients with IgA, but was not a significant predictor in the multivariable model. Role of galactose deficient IgA1. These slides show that we measured galactose deficient IgA1 in the serum using the KM55 ELISA kit in IgA nephropathy patients, disease control and healthy controls. We did 2 batches and both batches correlated, and we did not find that as a diagnostic marker in Indian IgA nephropathy. There was a significant correlation between serum IgA1 levels and galactose deficient IgA levels. And when we looked at its predictability as a risk factor for clinical outcome, though serum galactose deficient IgA1 predicted poor clinical outcome, it was a ratio of serum galactose deficient IgA to serum IgA, which was a much stronger clinical prediction in our cohort. There is a decrease in the levels of galactose deficient IgA1 in both groups at 1 year, probably an effect of immunosuppression, and then it goes up over time. These are the same things that I have reiterated before, so I will not repeat it. Going to inflammatory biomarkers, we did a set of Luminex experiments for a whole lot of inflammatory biomarkers in our cohort, and many of them were increased at baseline. Some ethnic differences, which courtesy to Professor Bharat, who is present here, it was compared with his cohort in UK as well as the Chinese cohort that he had. And we did find that there is differences in secretory IgA and galactose deficient IgA1, which was significantly less in South Asians compared to Caucasians, whereas the inflammatory markers had the opposite effect, where we had higher levels compared to Caucasian IgA nephropathy. So this is one of the last slides where where we have the current hypothesis of IgA nephropathy, which is a multi-hit hypothesis, and probably we will have to consider effect modifiers in our population, which could be low nephron number, inflammation or occult GI infections, altered gut microbiome, limited access to healthcare, genetics or epigenetics. Thank you for all my mentors and collaborators who have helped me in this work, and thank you.
I think we could have time for some questions if there are any. I don't see any in the chat box actually.
So we would like to take the questions at the end of the entire session,
Okay,
just to
sure.
save time.
Sure.
Santosh, if you are busy, you can take 1 or 2 questions. Padmini, if
Yes,
Santosh
ma'am.
is busy, allow him to take 1 or 2 questions.
Santosh,
Okay.
can you, if you can, 2 minutes, I think
Ma'am,
it will not be a
there are
problem.
no questions in the chat box.
No, so there are 2 questions by Abdul Hamidi. He has just asked about the importance of gut-kidney axis, on this axis in IgA nephropathy, and second is his question about the status of tonsillectomy in IgA nephropathy.
These 2 questions are not related to Susina's
So those are
presentation.
different.
Yeah,
Exactly.
we can take them later. And
Santosh,
probably gut-kidney axis will be dealt a little in the next presentation.
Yes, ma'am.
Santosh, can I ask one question to Susina?
Yes, ma'am, please go ahead.
Yes.
Susina, after your talk with all your differences in the ethnic differences in the inflammatory markers as well as on the galactose deficient IgA, would it be fair to say that our IgA behaves differently?
So that
Because
is
as you said, initially itself that it is not a randomized study, but then you have presented very robust data to say that we are different. And this question keeps on cropping up. And collateral to this is it important that we should immunosuppress them for a longer period of time rather than this short course of steroids, which we see with your study and with testing and all of it?
Yeah, thank you, Dr. Urmila. That's a great question. Both questions are open questions and there is no closed answers for it. So the first one, whether it's a different disease, I suppose there are differences. There are significant differences with regards to presentation. It's not just, I wouldn't say it's just late presentation accounting for the entire phenotype. There are significant differences even at the biomarker level. The second question with regards to immunosuppression, as long as we could suppress the immunity without the side effects of toxicity or infections over a longer time, that may be a feasible option.
Thank you, Susina.
Okay, if no further questions are there, we can move to the next session quickly. Next is Dr. Smita Divya's presentation. Can steroids in proteinuric IgA nephropathy help? Evidence from a short-term trial. And for this, I invite Dr. Arpita Rai Chaudhary, a keen clinical researcher and professor of nephrology at IPGMER Kolkata, and Dr. Manjusha, who is a professor and head Department of Nephrology at Gandhi Hospital, Hyderabad. So over to you, Arpita ma'am.
Thank you, Padmini. And I would take the advantage of setting the stage for Smita and Pradeep, who are 2 alumni of our institute and had done 2 small trials, treatment trials that may be able to answer Urmila's question a bit. Done that Urmila made. So I would like to set the stage for Pradeep and Smita. Yeah.
Yeah, Dr. Smita is assistant professor at PGIMER Chandigarh. She is very active and has done significant studies in this topic that we're speaking about. And the second topic will be discussed by Dr. Pradeep Das, who is senior resident from IPGMER Kolkata. So Dr. Smita will be discussing on can steroids in proteinuric IgA nephropathy help? It's in fact very crucial for us to know. So over to Dr. Smita. I think Dr. Smita is presenting.
Manjusha.
Yeah.
Manjusha, I would take the advantage to say the stage for the 2 trials. I'll just share a bit of IgA epidemiology. What Susina was discussing, little difference is there from in our cohort. So I would like to present that because
Yes,
that would
ma'am.
make
Please
it
go.
clear
Yes, ma'am.
that, make it
Sure,
clear
sure.
that,
Please go ahead, ma'am. Yes.
yeah. Thank you. We all know that IgA nephropathy is a very common glomerular disease worldwide, even if it's not the first, it's one significant, and mesangial IgA deposition and variable LM spectrum. Clinical presentations are variable, as Susina went on. Clinical course is also variable. When 40% of IgAN patients can progress slowly to ESRD over 20 years, there are few who progress rapidly, and natural question comes how to identify, and the IgA risk prediction is being available, and Susina has thrown some light with the biomarkers in Indian cohort that may help us to pick up the high probability ones who will progress to. From July 2010 to 12, when we were doing around 600 biopsies a year, we analyzed IgA nephropathy, which was 8.11% of our total biopsy cohort. So though we find a lot of IgA patients who have progressed subclinically and they are in our transplant list, sometimes we are not able to pick up those IgANs as diagnosed as IgAN probably. When they recur, we find IgA there, but we do not have any native kidney biopsy, which can show us that there was a rapid progression because they present with ESRD and proteinuria and hypertension. That cohort is a part of Indian IgA cohort, which is recognized at every large teaching center. That time we did find nephrotic syndrome as the commonest presentation, but as time went on, probably we picked up patients earlier from our OPD for biopsy, learned that we need to pick up patients early. And later on, when up till from 2013 to 2022, we analyzed the biopsy cohort, we found that our mean EGFR at presentation is not that bad as we were thinking about. It was around 63.3 ml plus minus 31.7. So we do get patients who progress slowly also. And mean proteinuria at presentation was subnephrotic. It was not always the late phase IgA that we pick up. Those are part, but we can pick up early phase IgAs too, where treatment may work nicely. And mean age of presentation is definitely highest in 21 to 30 age group. Males are in little in excess. Hypertension at presentation is present in about 70%, and most of them are getting ACE inhibitor or ARB, and some people are getting ARB not because they are hypertensive, but we are using ARB as antiproteinurics, and CCB, alpha blocker and beta blockers were used. So IgA, so hypertension associated with IgA are significantly severe, and sometimes they can present with accelerated hypertension even when we found with IgA some cases of TMA in our biopsy series. The syndromic presentation, as we were talking of, initially our biopsy analysis showed higher representation of nephrotic. Later on, we did get subnephrotic proteinuria as more common, and endocapillary hypercellularity, which is a measure of macrophage accumulation in the glomerulus, has been reported in 13% of European cases. Susina had shown it to be more than 40%. In our case, we didn't find it that high. You can see endocap hypercellularity in the range of 10.1%. Mesangial hypercellularity is the maximum. Maybe we were picking up some early IgAs as well. And moderate to severe tubular atrophy was also a part of IgA we were getting, and crescents were observed in 8.8% patients. Any crescent, 8.8%, and more than 25% crescents, 3.8%. IgA deposition 3+ or more in 58%, and C3 co-localization, as Susina's observation also went in, we did find, and Susina had correlated it with the outcome, which we did not, and she showed that it hardly is important as outcome predictor. So we had 238 cases of primary IgAN, which 35 is lost to follow up. Epidemiological data I presented, and we did 2 trials from 2015 to 2022, one observational trial of steroid intervention. At that point, testing was in the air. So we were also doing like testing, steroid intervention extending to less than 20 ml per minute EGFR, and an open label RCT, which we did later in proteinuric Indian IgA nephropathy patients. Can TRF budesonide improve the outcome? Smita will be presenting the observational trial as she did during her tenure of residency with us, and Pradeep, another senior resident, will present the second trial. Over to Smita and Pradeep.
Thank you, ma'am, for the elaborate introduction. I think you'll have to stop sharing the screen so that I can share.
Yeah, I have stopped sharing.
Okay. So are my slides visible?
Yes, Smita, visible.
Yes,
Okay.
yes, visible.
Okay. Good evening, everyone. Thank you for inviting me to speak about this work that I did as a resident in Calcutta. So I think we can skip the introduction. Madam has already done that for us, as well as given the background of the epidemiology that we used to see there in Calcutta. So this study was conducted from 2014 to 2017. Now in 2014, we only had the KDIGO guidelines to guide us about how to treat the patients with IgA, and it didn't have much to tell about the patients whose EGFR was lower. So at the time, the testing results were not available, and our ethical committee approved this study. So the inclusion criteria is quite similar to what testing had used. We wanted to see whether patients with lower GFR, lesser than 60 as well, would benefit from steroids. So the inclusion criteria was patients with primary IgA nephropathy who had a MEST scoring done on their biopsies, had an EGFR of more than 20, and were adults more than 18 years of age. So we excluded patients with secondary IgA nephropathy, IgA vasculitis, presenting GNs, pregnant women and children, and those with other diseases which could have caused worsening of kidney function independent of IgA nephropathy. All the biopsies were evaluated by a single nephropathologist, which was Dr. Anila Madam for us at the time. So the outcomes of the study were to look at the change in EGFR and proteinuria at 6 months and 12 months from baseline, and the association of the responsiveness to steroids with regard to the kidney biopsy findings. Now, the definitions of complete and partial remission are not very well established in IgA nephropathy, which is why we only chose at that time to look at the change in proteinuria and GFR alone and have not defined them as remission as such. Also, because IgA tends to behave a bit differently from our usual podocytopathies, where proteinuria remission alone indicates that the disease is in total in remission. However, in IgA, we have some disparity, as we shall see. So we screened almost 100 patients, and of them, we had to exclude multiple of them. Most of them had come with advanced diseases, and many of them did not have a MEST scoring of their biopsy. So finally, we could enroll only 36 patients, of whom 17 were with nephrotic range proteinuria on presentation itself. They were likely to progress faster, so they were put on steroids right away. The ones with subnephrotic proteinuria, this was a bit consistent with the KDIGO guidelines, where how the KDIGO guidelines do not tell us what to do with the GFR less than 60. But in this case, when the proteinuria was lower, we gave them ACE or ARBs as much as they could tolerate, and reassess them after 3 months. If they still qualified as per the inclusion and exclusion criteria, they were taken in for treatment with oral prednisolone. The dose we chose was 1 mg per kg per day, a maximum of 60 mg per day, which is somewhat equivalent to the testing study. The steroid that was used in testing study was oral methylprednisolone, but the conversion will get you a similar dose as this study. So we gave it for 2 months, followed by a slow tapering over 4 months. The testing study was subsequently modified in 2016 with a lower dose because of high rates of serious infections that they found. In our institute, it was a protocol to give Septron prophylaxis anyways, even for nephrotic syndrome. So that was a part of our protocol. These were the baseline characteristics. They were all young patients with an average age of 32 years. The average follow-up we had for this study was 14 months. And the male to female ratio was close to 1. The patients who had hypertension at presentations were fewer, although on follow-up, many of them required antihypertensives. And the body mass index was 22, not many obese patients. So in the ones who qualified for steroids, their clinical presentation was such: nephrotics were 9, nephrotic syndrome was the majority in 14% of the patients, nephritic 9, gross hematuria in 6 patients, and others, which included those who presented with chronic kidney disease, were about 6. So this is the table that shows the major results. So what happened at 6 months was a very significant reduction in proteinuria. So from what was a nephrotic range proteinuria, it became close to less than 1,000, which is good prognostic factor for IgA nephropathy. And the creatinine also improved somewhat. However, the eGFR values were not statistically significant. At 12 months, however, the proteinuria continued to remain low, but the improvement in creatinine from the baseline, this is comparison at 12 months from the baseline, that was no more significant, and the eGFR continued to remain insignificant. This graph only tells you the magnitude of decrease in proteinuria. Although there was increase in GFR, this was not significant at 12 months. When we looked at the association of their steroid responsiveness with their biopsy findings, by responsiveness, I mean both proteinuria and eGFR, either stability or improvement. There was only association with proteinuria reduction of the endocapillary proliferation on the kidney biopsy. The other components of MEST-C were not associated with any improvement in proteinuria or eGFR with steroids. Minor adverse effects were quite common. Almost half of the patient developed them. Most of them had Cushingoid facies. 2 of them developed diabetes. 1 of them had cellulitis and AKI, which was treated on an OPD basis. Serious adverse event only occurred in 1 patient, and this was a bacterial pneumonia, which responded to IV antibiotics. So the conclusion from this study of ours was that proteinuria did decrease with steroids, which is, as we understand, an important risk factor for disease progression in general, not just in IgA. However, it was disappointing in terms of improvement in eGFR. The overall adverse effects, although common, the serious ones were not so many. And of the MEST scoring, it was only endocapillary proliferation that was associated with proteinuria improvement. So MEST scoring may be useful in deciding if you should give immunosuppression, especially steroids. There are many limitations, of course, that apply. It's a smaller number of study. It lacks a longer follow-up and a randomized control design. But then I believe in IgA, we have many, many unanswered questions still. One of the most important one being, is proteinuria reduction equivalent to risk reduction in IgA nephropathy really? And does it apply to all cohorts or the different ethnic cohorts of IgA nephropathy? So thank you for your patient listening. Over to you, Arpita Madam.
Madam, you have to unmute, Madam. Arpita Madam.
Sorry. So I may ask Pradeep to move forward with his presentation. The budesonide that we had used was the budesonide that is available for use in gastroenterology in our Indian pharmacopoeia. It's not the Nefecon that was used in the Nefigan study by Professor Bharat and his co-investigators. It was the topical release budesonide that was being used in gastroenterology for ulcerative colitis. And it was available as per Indian Pharmacopoeia, and our ethical committee had approved that.
Thank you, madam. Good evening to the chairperson, to my seniors and colleagues, and to the organizers. Thanks to all the person. So I'd like to start the presentation, my trial as it is enlisted.
Pradeep, can you put it in slide
Slideshow.
mode?
Slideshow.
Slideshow
Yes, ma'am.
at the end, at the bottom.
Pradeep, go to the toolbar at the bottom. You will find the slideshow, or you can move up as well.
Yes.
Go down toolbar, go to the down toolbar.
Pradeep sir, where this 68 has been written, just beside that 68, there is a sign at bottom right corner, sir.
Actually, in laptop, it is already in share mode.
Yeah, you are sharing, but you are sharing not the full slideshow.
I think sometimes it happens. It's better to proceed than rather than wasting the time.
Yeah.
Pradeep sir, instead of the PPT, just click on share screen and select the screen. So you will get the full access, sir.
Now it is okay.
I think no.
Yeah, you can continue with this, Pradeep, Dr. Pradeep.
Yeah. The trial is the targeted release budesonide therapy versus conservative management in IgA nephropathy, an open label randomized control trial, and it is already registered with the CTR. So introduction, as it is already covered by Arpita madam. So I like to tell the rationale behind behind this study. As we already know that IgA is a multi-hit pathogenesis.
If you have to move your slides, please. You're stuck on the next slide. You have to move.
Actually,
can you send your slides to Siddharth?
Until you go in the slide share mode, slideshow mode, you won't be. Yes, now it's moving.
Now start.
Yeah.
So the rationale behind the study is multi-hit. As we know that multi-hit pathogenesis of IgA nephropathy, which includes synthesis of galactose deficient IgA1, anti-glycan antibody production, circulating IgA1 immune complex formation, and glomerular deposition triggering inflammation and damage. So the question is, can steroid help as an anti-inflammatory mediator in IgA nephropathy? So the second is that, as we already know, that primed mucosal B lymphocyte in pairs patches producing galactose deficient IgA1, capable of forming large immune complexes with circulating anti-glycan IgG antibodies. The second rationale is that oral steroids may be effective but potentially harmful. So we have tried budesonide in IgA nephropathy patients, as the uniqueness of this drug is that this glucocorticosteroid budesonide released in the distal ileum, which has a higher density of pairs patches. The high ratio of local activity compared with the systemic effects of oral budesonide is attributable to several properties. The first one is the active budesonide for glucocorticoid receptor is 15 times more than the predecessor. And encapsulation formulation allow pH and time dependent release at targeted areas of the GIT. And extend first pass metabolism via the cytochrome P450 system results in low potency metabolites, minimizes systemic exposure to active drug absorbed from the ileum and subsequent off-target effect. So the question is that proteinuric Indian IgA nephropathy patients, can TRA budesonide improve the outcome? So we have taken the inclusion criteria for our study as a age of 18 years old, male or female with IgA nephropathy proven by biopsy with proteinuria more than 1 gram per day with eGFR of 45 ml per minute per 1.73 meter square. And exclusion criteria is the standard exclusion criteria, especially the IFTA in renal biopsy more than 30% and uncontrolled blood pressure of more than 160 by 100 millimeter of mercury after run-in phase. So trial description, it is an open label RCT comprising of 6 months run-in, 9-month treatment phase, and 6 months follow-up. And of total 71 patients screened, 65 were enrolled for the run-in phase, and those have received non-immunosuppression in the last 6 months. And of these 63 patients, we have randomized 53 for the trial phase, and of them, and randomized allocated in 1:1 fashion, and 26 in the control arm and 27 in the intervention arm. And the patients in the intervention arm were followed up for another 6 months after completion of the treatment.
Primary outcome.
So,
Pradeep,
yes.
show the primary outcome.
Yeah.
That was in the last slide. Yeah.
So primary outcome were to measure the change in 24-hour urinary protein excretion and change in GFR at the end of the treatment. And safety was assessed in all patients throughout the study period. So this is the baseline characteristic of our study population. The mean GFR was 82 ml in the control arm and 80 ml in the intervention arm. And 24-hour urinary protein, the mean was 2.3 gram in the control arm and 2.4 gram in the intervention. And all of the patients in the control arm and intervention arm have received ACE or ARB as antiproteinuric or antihypertensive. So baseline features, other baseline features were more or less similar in both the arms. So this is the graph showing the trend of 24-hour urinary protein excretion in the control arm, which it is demonstrated in the graph that at the baseline it is around 2.3 gram, and at the end of 9 months it is around 1700 milligram per day. Similarly, for the intervention arm, we have plot the graph for 24-hour urinary protein. The mean was 2.4 gram at baseline and 812 milligram at the end of the 9 months. So there is also significant decrease in proteinuria when we applied adequate antihypertensive, including ACE/ARB or other antihypertensive drug. So in this slide, we have plotted the comparison of eGFR in the intervention arm and the control arm, which is at the end of 9 months, the mean eGFR was 78 ml in the control arm and 90 ml in the intervention. And similarly, in the similarly for 24-hour urinary proteinuria, in the control arm it was 1700 milligram at the end of 9 months in the control arm and 812 milligram in the intervention arm, showing significant decrease in proteinuria in the intervention arm. So how long we analyzed for longer follow-up data post 6 months TRF budesonide withdrawal. So while looking into the outcome post 6 months of withdrawal of budesonide, out of these 27 patients who received budesonide, 4 had uncontrolled blood pressure, hence excluded from the analysis. Out of the rest 23 patients, 12 had increased proteinuria after withdrawal of the TRF budesonide. Patients with rising proteinuria had started documenting marginal rise in creatinine. So patients with reduced GFR with increased proteinuria were number was 12, and patients without increased proteinuria but with reduced GFR was 4, and with stable GFR without increased proteinuria was 7. So after looking into this finding, we have analyzed the baseline histology finding among our patients. So it was observed that patients with increased proteinuria were of younger age group and had had M1/E1 lesions in their renal biopsy at the baseline. So in the adverse events, there was minor adverse event. There is no major adverse event like hospitalization or death during the study period, and after also during the follow-up period also. In a intervention arm, only 2 patients turned out to be pre-diabetic, and others side effect profile was more or less similar in both the groups. So conclusion of the study, this study showed that on top of optimized RAS blockade, addition of TRF budesonide as adjunct therapy in patients with IgA nephropathy with persistent proteinuria more than 1 gram per day can further reduce proteinuria and stabilize eGFR. TRF budesonide has the potential to become the first disease-specific treatment for IgA nephropathy with an acceptable risk-benefit profile, and duration of therapy to provide sustained benefit is yet to be determined presence of mesangial and endocapillary proliferation may need longer therapy. The uniqueness of this trial is that we have followed the patients for another 6 months after completion of 9-month study period, and the trend of eGFR and proteinuria during the 6 months follow-up period were measured. And Indian IgA nephropathy cohort is considered as more aggressive than its Western counterpart. So whether the success with Nefigent trial will be reproducible in our patients or not. I would like to give over to Arpita madam for here.
Thank you, Pradeep, for and Smita too, for nicely showing us the study results. And when the two trials taken together, I translate in practice that shows me that with a very acceptable risk-benefit profile, we may consider that TRF budesonide may be added as a disease-specific therapy for IgA nephropathy. On top of that, what we were seeing in Susina's work, that the inflammatory mediators are relatively high in Indian IgA patients. So we need some form of anti-inflammatory therapy. Steroid is more anti-inflammatory and a weak immunosuppressive. And we may do so that the higher proteinuria patients who may require a 3 months aggressive steroid therapy can be given steroid therapy at that point of time, and on follow-up they may be followed up with the TRF budesonide for longer steroid therapy. The question which Urmila was raising, the duration of therapy is yet to be answered, and we may find out the more risky patients who may need longer TRF budesonide on top of steroids. And I would like to know Professor Barrett's opinion about this.
So thanks very much. A really nice set of talks. I really enjoyed those. I think at the moment we really don't know how long to give budesonide for. The study has only been 9 months, but the current phase 3 study has an open label extension. So we are going to see the number of patients that need retreating after a couple of years and what the impact of retreatment does. So we are collecting that data at the moment. So it will be data that will come out over the next year or so in terms of how long we can expect a response with Nefecon and how often we might need to retreat. So that data will be coming, but we don't have it just yet.
Thank you.
Peter, can I ask Professor Barrett one question?
Yeah, sure, Urmila.
Professor Barrett, why do we need to stop TRF budesonide? What is sort of preventing us to continue it as we continue steroids in transplants, we continue low-dose steroids in SLE, vasculitis? Because if you look at Susina's data, our IgA is very inflammatory. All the inflammatory markers are very high. So why are we only stopping at 6 months, 1 year, and not continue longer?
So that's a really good question. I think that the bottom line is, I think people are just worried about so it's equivalent to about 5 to 10 milligrams of prednisolone in terms of systemic absorption. And so what we're not sure about is how bone health will behave over time, what cardiovascular risk profile will behave over time. I think if the data from the NefIgArd study, because at the moment we only have from the phase 2 12-month data. So if the data shows that actually proteinuria comes back pretty quickly when you stop, there would be an argument potentially to keep this as a chronic therapy, perhaps start with 16 milligrams and go down to 8 milligrams long term. Or it may be that actually we would just treat based on proteinuria. So we may give a 9-month course, monitor proteinuria. If we see a proteinuria rise, we'd then trigger another treatment cycle. And that may well be occurring at different times in different patients, depending on their disease activity. So there's a lot we still don't know about this approach. And it may be that some of our patients are going to need continuous therapy. And some may get away with just intermittent treatments. We just haven't got that level of data yet.
Thank you,
Why
Professor
don't we,
Bharat.
one more, Arpita, one.
Yeah.
Why don't we develop a marker like vasculitis or SLE, a ratio, as Susina says, of galactose deficient IgA and normal IgA, and then use that marker to decide treatment duration?
So,
Madam,
so it
Madam,
will be. Oh, sorry.
Yeah, please go ahead, sir. Please go ahead.
So I think, Amila, we've never had a drug that really drops Gd-IgA1 until we have started using these BAFF and APRIL inhibitors. And it may well be that we will be able to use Gd-IgA1 as a biomarker to monitor response going forwards. But at the moment, you know, the bottom line is that we've only got data on 26 patients globally where we've seen substantial reductions in Gd-IgA1. So we don't know how that relates to future kidney function protection. And we don't know, because these drugs haven't been stopped, whether it bounces back. But it's a very good point. And we may well be able to use Gd-IgA1 for certain therapies that target exclusively B cells, but we might need different biomarkers for some of the other drugs that target different things. So I wouldn't imagine using Gd-IgA1 would be good if we were looking at a complement inhibitor, for instance, because I don't think a complement inhibitor is going to do anything to Gd-IgA1. And there we might be looking at a urine complement marker. But for a B cell therapy, we might be looking at Gd-IgA1. So I think we've got to think, you know, going forwards, what's the right biomarker for the particular treatment we're going to use.
Dr. Barrett, just wanted to know from you, I mean, in most of the newer trials, do you think SGLT2 inhibitors should be used as standard of care along with RAS blockers before we try the immunosuppressant drugs? Do you think, I mean, has that time come?
So all we've got is the DAPA-CKD data. I'm not doing it myself at the moment. I'm waiting to see what EMPA Kidney shows. EMPA Kidney has 800 patients with IgA nephropathy in it. So we're going to have some really good data on the usefulness of SGLT2 inhibitors in IgA in that cohort. I think we, you know, the likelihood is it's probably going to show what it does in general CKD, in which case SGLT2 inhibitors are likely to become part of that supportive care regime that we do. But at the moment, I'm not committing a 20-year-old to a lifelong treatment with SGLT2 inhibitors based on the DAPA-CKD data alone. I'm absolutely using it, SGLT2 inhibitors, in my older patients who also have coexistent vascular disease and IgA nephropathy, because I think the data there on cardiovascular outcomes is very strong, but not in a 20-year-old with single organ IgA and nothing else. I'm not using it in those patients at the moment. I'll wait for EMPA Kidney to give me some more data first.
Professor Barrett, may I share a few observations of our OPD where few patients of IgA were given SGLT2I on top of RAS blockade, and 3 of them landed in AKI, 1 in severe dialysis requiring AKI, and after SGLT2I withdrawal, we did have reversal. In 1 patient, we had done a biopsy which revealed AIN.
So I think that's really interesting, because I put all my patients with IgA nephropathy who weren't eligible for an IgA nephropathy trial into DAPA-CKD. And I have to say, I did notice some deteriorations in those patients, but of course they had advanced CKD, which is why they couldn't go into the IgA studies. I think the EMPA Kidney study is going to be really useful. Now, I don't know, did EMPA Kidney recruit in India?
No.
Institutes.
No, so again, I think we always need to be cautious of just assuming what we see in Caucasians works for the rest of the world, because I know that's just not the case. So I think it's going to be important, and I know that there, and I don't want to speak out of turn, but there are certainly thoughts about looking at SGLT2 inhibitor use in IgA nephropathy in Asian patients. And I think that would be a really useful study to do, to be able to see whether there are any peculiarities about how South Asian patients respond to SGLT2 inhibitors. So at the moment, I'm waiting for EMPA Kidney before I make any decisions in all my IgA patients.
Shanilata, we may proceed for the next session because time will be a constraint factor.
Yeah,
We
sure, madam.
eager to hear from Professor Barrett as well.
Okay.
Sure, madam.
So the penultimate session would be, is IgA vasculopathy the missing link in risk prediction for IgA nephropathy? And Dr. Siddharth will solve this mystery for us along with the expert chairpersons, Dr. Anila Abraham. She's an excellent renal pathologist from Renopath Center, MMC Chennai, and our workaholic professor, Dr. Swarnalata from NIMS Hyderabad.
Yeah, thank you, Padmini. So it's very exciting to see this lot of data on IgA nephropathy, the Indian data. So as we have seen, it is quite different from the Western. We need to have our own, strategies and then plan our own treatment protocols. So I mean, similar is our experience. We try to analyze our data of last 3 decades, and we have done around 5,000 biopsies. And what we have realized is it's the incidence of the IgA nephropathy is increasing, probably because of increase in the biopsy with patients coming with asymptomatic urinary abnormality. And the presentation, it has, I mean, it was 2% 3 decades before, and now the last decade, its incidence has increased to 8%. And even the presentation has changed. Initially, it was the CKD, the most common presentation. Now it is the acute glomerulonephritis, followed by nephrotic syndrome, and then we have the crescentic glomerulonephritis, and the CKD has taken the last seat in the presentation. So there is a changing scenario of presentation, and we have seen that there is a lot of inflammation with this Sucina's data. We have seen that there is a lot of inflammatory markers, biomarkers in Indian population. So the same thing we'll try to share in our experience, and we have tried to analyze around 100 patients, and out of this 50 patients we could actually get the vascular changes. So we want to emphasize the importance of these vascular changes in taking the decision on whether they require immunosuppression protocol and how long to be treated, and so also the prediction in the outcome. So in fact, these can be correlated well with the inflammatory markers what Susina is looking at, and we can design our own the treatment protocols. So I would like to invite Dr. Siddharth. He has done his thesis on that. He has done in 2 parts. The first part is not presenting, is on basically on how they have presented and what treatment protocol we have given and what were the outcome. We want to emphasize the second part, which is the IgA vasculopathy. Is it a missing link, and is it a time to incorporate this vascular segment also in the MES scoring? Over to you, Siddharth, please.
Good evening, everyone. Am I audible?
Yeah, yes, you're audible. Please go ahead.
Are my slides visible?
Yes, please.
Yes, okay. Good evening, everyone. I thank Win India for this opportunity. So I'm here to present a small study done in our institute under the guidance of Dr. Swarnalata. It's IgA vasculopathy and its role in prognostication. So a brief introduction, as all the speakers have said time and again. So this is the most common primary glomerulonephritis, and very unique features for this disease that it has got a very broad clinical presentation, and it is difficult to stratify and treat, and also it has a variable natural progression. So when patients present to us with a common diagnosis of IgA nephropathy, but the diagnosis is common, but the patients are different. So what we see across India, and as Dr. Saxena has presented from CMC also, that it's an extremely heterogeneous population and also heterogeneous risk of progressive kidney function decline. So the 10-year risk of ESRD varies between 5 to 60%. So you can see the huge difference in the percentage. And some proportion of patients, the course is very benign, they do not need anything, whereas others, they present for the first time with advanced disease and renal failure. So there is a clear need for an accurate tool to predict disease progression. And the prognostication at the time of presentation is of paramount importance, and we have to individualize treatment for each and every patient. The treatment is different. Which patient responds to immunosuppression, which patient needs immunosuppression, which patient does not. So the risk progression assessment or prognostication should be individualized, and it is very important in IgA nephropathy. So what do we have till now in the prognostication of IgA nephropathy? The new international risk prediction tool in IgA nephropathy is very well known, and it is officially endorsed by KDIGO, and even they have shared the link in the KDIGO guidelines that every patient should undergo this evaluation at the time of diagnosis, at the time of presentation with this risk prediction tool. As you can see, this risk prediction tool has incorporated both including demographic variables, clinical variables, and also histopathology. and also treatment details like use of immunosuppression and use of AC inhibitor or ARB. So this is a composite risk prediction tool, which was thought like it will answer all the questions of IgA nephropathy. So when it was published in 2018 in JAMA, so everyone were very happy, and it included patients from Europe, North America, China, and Japan. So, but still it needed external validation. So every country almost did a study to externally validate this risk prediction tool. For example, this Greek study, which did externally validate IgA risk prediction tool, but found out that it had inferior performance on a personalized risk assessment. This Chinese study was very much happy with the IgA nephropathy prediction tool, and our own Indian population also. From the All India Institute of Medical Sciences, Dr. Soumita Bagchi et al. Have done a validation study on this IgA nephropathy prediction tool. And they have clearly mentioned in the study that it underestimates disease progression in Indian patients. So as you can see, this risk prediction tool has involved from demographic to clinical to histopathological variables, but still it did not estimate the disease progression in Indian patients, it underestimated. So what else, what is missing? Why are we missing this disease progression risk assessment in Indian patients? So in this quest to know what is missing, so we wanted to investigate the vascular lesions, which always are missed, and to investigate the vascular lesions in the histopathology and to estimate their prognostic values in patients with IgA nephropathy. So the objectives were to estimate the prevalence of vascular lesions, association of vascular lesions with clinical variables and histopathological variables at presentation, as well as the strength of vascular lesions in prognostication of IgA nephropathy. So it was a single center retrospective observation study. So all biopsy-prone IgA nephropathy in the last 5 years were included in this study, and all secondary causes, age less than 18 years, inadequate renal biopsy defined by less than 8 non-sclerotic glomeruli and 2 arteries and arterioles were excluded, and with follow-up less than 6 months were excluded. So after excluding all these causes, we could narrow down to 53 patients who were included in this study. And all these 53 patients, the histopathology slides were retrieved from the archives and were reviewed by a pathologist freshly. And a vascular score sheet was given to all these 53 patients. So the vascular lesions defined in this study were divided into chronic and acute. So the chronic lesions studied were arterial fibrotic intimal thickening, arteriolar hyalinosis, and the acute lesions studied were arteriolar inflammatory cell infiltrate, arteriolar endotheliosite swelling, and arteriolar thrombosis. So these were the acute and chronic lesions studied in all the 53 slides, which were retrieved and re-examined by a pathologist. And it's important to notice here the pathologist was blinded to the clinical data. The pathologist didn't know who did well and who did not. So for all the 53 patients finally included in this study, we devised a vascular score sheet. A vascular score sheet was scored. So these were the acute lesions studied, and these were scored like if arterial endotheliosite swelling is there, the score was 1. If it was absent, the score was 0. Similarly for inflammatory cell infiltrate and also thrombosis. So one more important thing was we did allot them a composite acute score with the maximum score of 3 and minimum score of 0. And coming to chronic lesions, arterial fibrotic intimal thickening in the interlobular and arcuate arteries was studied, and also arteriolar hyaline. So the reference score was for intimal thickening. If the patient had thickening less than the thickness of the media, it was labeled as, it was scored as 1. And if the thickness was more than the thickness of the media, it was scored as 2. So finally, the composite chronic score was maximum of 3 and minimum of 0. So these composite scores were very important. So coming to the results, so the mean age was 30 years, and gender, there was a slight male preponderance. Creatinine baseline was 2.1 and EGFR was 44, proteinuria was 1.7 gram. Systolic blood pressure was 150, diastolic blood pressure was 92. Duration of symptoms, 4 weeks was the median. So coming to histopathology, the different MEST-C scoring, different components of the MEST-C scoring are represented here. The and it is important to notice here that a significant proportion of patients already had a chronicity in the form of T1 and T2 lesions and also sclerosis. From the time of diagnosis, 80% of people were started on RAS inhibition, and 70% received immunosuppression in one form or the other. So coming to the lesions, so as described previously, the acute vascular lesions, we found out that 66% of the patients had acute vascular lesions and 54.7% of the patients had chronic vascular lesions, as defined by in the methodology. So this is a significant percentage, even more than some of the MEST-C components. That is very significant to notice here. And among the acute vascular lesions, arterial or endothelial site swelling had the maximum percentage of around 40%. And one more important point to notice is the thrombotic lesions also were very significantly high compared to the rest of other population, other cohorts. And the chronic lesions, 38% was arterial fibrotic intimal thickening, and hyalinosis was also noticed in more than 30% of patients. So when studied to see for any association with the baseline clinical variables like eGFR, proteinuria, hematuria, and blood pressure, it was found that the composite acute score significantly was correlated with the eGFR and hematuria, hematuria being one of the markers of disease activity, and also blood pressure. Similarly, chronic scores significantly correlated with the blood pressure at presentation. And coming to the MEST-C components, it is important to notice here that among the acute lesions, only the inflammatory cell infiltrate correlated with the crescents. And apart from that, there was no significant association between these lesions and the MEST-C scoring. All the very important reason for us to introspect and see what is causing these lesions. Is it the same pathogenesis as the mesangial hypercellularity and endocapsular hypercellularity that is causing the same endothelial lesions, or is it different? And coming to chronic lesions, of course, chronic lesions, there's no much surprise here. They were correlated, they significantly are associated with the sclerosis and the tubular atrophy lesions. So coming to the outcomes in this 53 small cohort of 53 patients, 53% of them achieved complete remission. 32% of them, 13% of them achieved partial remission. 32% of them went on to progress to ESKD. This is a significant percentage of patients progressing to ESKD, 32%, and the mean duration was around 19 months. So this is the primary outcome studied, ESKD. So when these vascular lesions, so that is the composite acute score and the composite chronic score, with the at present recommendation of risk prediction tool, which is recommended by KDIGO, when this was plotted in an ROC curve, as much as the risk prediction tool, the composite acute score and the composite chronic score also independently was associated with the risk with the ESKD progression. So the area under the curve also was very much similar to the risk prediction tool area under the curve. So that means as much as the risk prediction tool predicts the ESRD progression, the composite acute score and the composite chronic score also predict ESKD progression independently. So this was inspired from a study done by Zhang et al. In China, where the acute vascular lesions were reported as 39.6%, but our study showed a very huge percentage of 66%, as mentioned, even higher than the MEST components. And the chronic vascular lesions were very much similar, and endothelial site swelling was the most common lesion. So what do we know about vascular lesions in IgA nephropathy till now? So the Oxford classification of IgA nephropathy, when it was published for the first time, they did study the arterial lesions before publishing, and this was the original score sheet of the Oxford classification published. And as you can see in the right down corner, arteriosclerosis and arteriolar hyalinosis were indeed studied whether they had any association with the disease progression. But arteriosclerosis and arterial ilonosis was not included in the final MEST-C because they did not find any association with the outcomes. As well as a French study, contrary to the Oxford classification, a French study showed significant association of vascular lesions with the outcomes. As well as an European study also shows advanced vasculopathy was included in IgA nephropathy progression. And this was the study Zhang et al., where they have showed intrarenal arterial lesions are indeed associated with higher blood pressure, reduced renal function, and poorer renal outcomes in patients with IgA nephropathy. And even the very recent study, arteriolar C4d in IgA nephropathy, also showed that the C4d staining in arterioles, which was the predominant vascular lesions we studied. So even if it is complement mediated inflammation, it is seen in arterioles also. So arteriolar C4d also was associated with the progression to ESKD. So the overall prevalence of vascular lesions in the histopathology was 72%, if you include both acute and chronic. And acute vascular lesions was 66% and chronic vascular lesions was 54.7%. And arterial endothelial swelling is the most common vascular lesion. The vascular lesions are also an independent predictor of ESKD progression. So we feel that it is high time that we include vascular lesions in the regular reporting of IgA nephropathy, and probably devise a vascular scoring at the time of diagnosis, just like how we do MEST-C scoring, and see whether we can predict the risk progression and prognosticate IgA better, because prognostication is very important in deciding treatment strategies. Thank you.
Yeah, thank you, Siddharth, for the presentation of the data. I would now request my co-chairperson to comment, please.
Thank you so much, Dr. Swarnalata and Dr. Siddharth. That was an excellent study. And just like in lupus nephritis also, where a vascular component is lacking in its activity and chronicity index, though we know that, a vascular lesion really plays an important role. So I guess with the next modification of these scorings, both lupus nephritis and IgA nephropathy will have, or hopefully should have, a vascular scoring. I just have two questions to Dr. Siddharth. First is, you had mentioned about the inflammatory infiltrate in the arterioles. So whenever, that's basically what, vasculitis. So have you ruled out, or shouldn't you be ruling out ANCA in those cases? Because we do occasionally see superimposed ANCA-associated vasculitis. So was that done in all your patients who had inflammatory cells infiltrating the arterioles?
Yes, madam. Yes, we did exclude ANCA vasculitis, as well as IgA HSP vasculitis also was excluded, if at all was there. So it was pure primary IgA nephropathy cases that were included.
Causing vasculitis. Right.
All secondary causes were excluded when we had almost 100+ patients, but after excluding all this, we have ended up with analyzing only 50 patients.
All right. And the second thing is, sometimes quite often we see severe malignant hypertensive changes, the typical onion skinning appearance. Did you have any of your patients showing the characteristic malignant hypertensive changes and IgA nephropathy being, in a chronic or an advanced stage? Because quite a number of patients present that way, where the presentation is of a malignant hypertensive nephropathy, but the IF, and probably 80% globally sclerotic glomeruli, but the IF shows that there is a good amount of IgA. So it is IgA nephropathy which has progressed, and the patient has a uncontrolled hypertension, and only then is the patient presenting to the nephrologist. So that's not an uncommon biopsy presentation that we have in our population. So
yes,
did
may I put one observation to Anila's? Yeah, Anila, I do agree with your observation. We also, particularly the advanced CKD presentation IgA, they have such onion skinning in the vessels and malignant hypertension as presentation. Yeah,
Yes.
Siddharth, please.
Yes, Siddharth, just wanted to know, how many patients of IgA without hypertension had vascular lesions? Were the vascular lesions in your study because of IgA, or they were because the TMA and vasculopathy because of hypertension?
Yes, madam. So the acute vascular.
Siddharth, go ahead, then I'll comment.
Yes. So that is, it is difficult to say whether it is due to hypertension or the disease per se. That is why different vascular lesions were studied, and the composite score finally was studied with for any associations rather than a single vascular lesion. Because we tend to, if we see malignant hypertension induced TMA, we tend to just say that malignant hypertension is causing TMA and not the IgA nephropathy. In that way, we might be missing what exactly IgA nephropathy is causing the damage in the vessels. That is why we did include the composite scores rather than a single score. And it is difficult to say whether it is due to malignant hypertension, especially the TMA, the thrombosis lesions, whether it is due to malignant hypertension or the IgA per se. But onion skinning was not included in the vascular score sheet, so onion skinning was not there.
So how many patients of IgA did not have hypertension and still had the vascular lesions? Did you have any such?
Manisha, this was actually a retrospective data. So we have tried to collect all the data, and then we have blinded our pathologists with the clinical presentation. So we have looked at what was the presentation of the hypertension. So as you might have seen in our data, that presentation as the hypertension was very less. Most common presentation was actually acute glomerulonephritis followed by nephrotic syndrome, and even RPGN and hypertension was the least presentation. So at this time, probably we cannot be very sure that they never had a malignant hypertension. This could be there's some overlap, but at the same time, I like to emphasize that was not only the finding, we could also analyze the other findings, and that's why we have put the concept of composite, acute and as well as chronic, which would help us in predicting the outcomes.
So these patients with nephrotic syndrome, was EM done to rule out an associated MCD?
No, EM was not done in our patient group.
So Anita, we move on, wait for Professor Barrett's talk.
Yes, please, yes.
Can we ask for Professor Barrett's comment on this aspect, Shanulata, about vasculopathy in IgA?
Yeah,
because we are getting primary TMA and IgA together.
Yes, if you can have the expert comment on this, I think that's something like ultimate.
Yeah, I think you've really kind of covered the main. It's just a catch-22, isn't it? Is it hypertension driven, or has hypertension come as a result of significant glomerular injury? I mean, I think there is certainly evidence that the complement system can be involved in endothelial cell injury and these vascular lesions, as you might see in a TMA or an atypical HUS type disease. And there's that study from Paris that looked at these lesions and certainly there's data from Chinese cohorts that TMA lesions do exist in IgA nephropathy. It's not something I see very commonly in a Caucasian population. But I do think it's really important to work out which of those are driven by uncontrolled hypertension. But I actually think there is a minority of patients who have true endothelial injury and may well have a very different type of disease. And I think you're much more likely to see it in East and Southeast Asia than I do in Caucasian populations. But we really haven't teased out the blood pressure relationship there. But I definitely think there are a subgroup of IgA patients who have a true endothelial injury syndrome, and that's likely driven by complement activation.
Yeah, and with this experience, if we can plan for prospective studies with, as Siddharth has emphasized, the arterial wall C4D and then the inflammatory markers, probably we can definitely tell whether it's because of the secondary malignant hypertension or the endothelial cell injury secondary to IgA nephropathy.
Yeah, and we're so one of the things we're doing in Leicester and a couple of sites in the UK is trying to think what other complement stains we could reliably bring into a routine kidney biopsy situation. So I don't know about you guys, we would do a C1q and a C3 and that would be it. But what we're working and optimizing is a C4D because actually the staining for C4D in native kidneys is very different to the way we stain for C4D in transplants looking for antibody-mediated rejection. The background is just too high with that methodology, we found. So we're optimizing the C4D for glomerular staining in native kidneys. We're looking at C5 beta 9, so the terminal complement complex, but we're also looking at markers of inflammation associated with that complement activation. So staining for CD68 positive macrophages as well. And so we're looking at whether we can introduce that into a routine assessment for all kidney biopsies. Because I think if we start getting these alternative pathway and lectin pathway complement inhibitors, which are going to be incredibly expensive, we want to make sure we're giving them to the right patients. So, you know, if we get a C1q negative, C4D positive kidney, that's strongly suggestive of lectin pathway activation. Whereas if we get C4D negative, but C3 positive, then we're thinking alternative pathway. So that's what we're trying to do to see whether we can get it into routine practice. But I think we are absolutely right. We're going to need to have a panel of more staining for our kidney biopsies to really tease this out, particularly when there are going to be new treatments and they're all going to be very, very expensive. So we are not going to want to give these treatments to people if we don't know they're likely to benefit.
Thank you, Professor Bera.
That comments will be more on to the next session, please.
Okay, so that brings us to the session we all have been waiting for. We have been hearing Dr. Jonathan Barrett in bits and pieces, and now we hear him in totality when he'll be giving a comprehensive update on IgA nephropathy, past, present, and future. Dr. Jonathan Barrett is a professor of renal medicine at University of Leicester, UK. He is a principal investigator for the international RCTs in IgA nephropathy. He's also an editorial board member for Kidney International and Clinical Journal of American Society of Nephrology. To chair the session, we have three eminent Indian nephrologists, Dr. Georgie Abraham, who is a senior consultant and nephrologist at MGM Chennai, and he has mentored many a nephrologist, so we all know him. Dr. Urmila Anand, she's an extremely learned senior consultant of nephrology at Yashoda Hospital, Telangana. And obviously the enthusiastic and an excellent teacher, Dr. Manisha Sahai ma'am, who is a professor and head department of nephrology at Osmania General Hospital. All three of them will be chairing this session. So may I ask Dr. Urmila ma'am to carry forward this session?
I think Dr. Georgie Abraham has not joined. Manisha, you can introduce Dr. Jonathan Barrett. I had the privilege of inviting him to Hyderabad. And we had an excellent session. Him, Professor Alan Salama, and Dr. Stephen McAdoo, and we learned so much from him. Manisha, over to you.
Yeah, good evening all, and I mean, good morning, good afternoon, whatever time zones we are all present. So it's my pleasure to invite and introduce Dr. Jonathan Barrett. We know him as the IgA nephropathy man, and then the top-notch person in IgA nephropathy, and is involved in so many trials of IgA nephropathy. So I mean, his name is synonymous with IgAN. I think all of us know him. He is professor of renal medicine and IgAN researcher at University of Leicester, UK. And as Dr. Urmila said, we always learn a lot in all his discussions. He was recently giving a talk at SGPGI Lucknow, and we were amazed with the depth of his knowledge. So over to you, Dr. Barrett. We would like to hear from you about IgA nephropathy, what's there in the future for us. We have heard about Indian IgAN, so kindly share your experience, the past, the present, and future. So over to you, sir.
Thank you very much. So I'm just going to share my screen. Just make sure you can all, can you see my slides okay?
Yes, sir.
Yes, sir.
Yep. So it's a real pleasure to be with you, but it's also a real shame because I've missed out on coming to India over the last few years for obvious reasons, but I've never been so well looked after and had such a warm reception as when I've been to visit units in India. So I hope this will start again very soon because I do miss traveling to meet you all. But what I'm going to do in this talk is focus around the science behind the new therapies that are coming out and give you a feel for the work that's going on, understanding what's happening in the immune system and the kidneys, and the rationale for why we're developing the treatments that we are currently testing. So I don't need to tell you guys how important IgA nephropathy is. And you've had some very nice talks talking about IgA nephropathy in South Asian populations that we've just heard, some really nice work. This is a significant problem for our patients. It is a disease that progresses to end-stage kidney disease. We do not have safe and effective treatments at the moment, and our patients are crying out for new therapies and new ways for us to allow us to plan how we're going to manage them. And it's great to see really exciting work coming out of India, looking at the South Asian population, because I think, as you've already heard, it's telling us really important information about IgA. And as I've said to many people, the type of IgA that you see is completely different to the IgA that I see in Leicester. And the type of IgA seen in Japan and China is different again. And we really need to start understanding what's different about this disease, because that's going to help us understand what are the right biomarkers to use and what are the right treatments. Just a rough estimate of the global burden. And I think, you know, in terms of India, that is going to be incredibly large in terms of the number of patients you have diagnosed, but also those undiagnosed patients that are out there with progressive CKD. So as has already been mentioned, it's the commonest pattern of glomerulonephritis in the world, but it is only a pattern. It's a pattern of glomerulonephritis defined by what we see down the microscope. And that's important to understand. Rather like FSGS being a pattern of glomerular injury, IgA nephropathy is defined by the immunoglobulins and immune complexes that are deposited. So it's a predominant or codominant IgA deposition associated with a variable kidney biopsy feature. And you've heard about what the kidney biopsies look like from Cecina's work at diagnosis, and that's very, very different to the biopsies I see in my patients with IgA nephropathy, and it's very different to, again, the patients that are seen in Japan and China. So the kind of features we're seeing on biopsies is very, very different, both within populations but across populations. And I think we'll all accept that there are many variations in what we see in terms of IgA nephropathy. We see differences in geographical prevalence, clinical pattern, the pathology I've just mentioned. The genetic studies suggest differences in genetic predisposition, pathogenic pathways, and response to treatment. And so perhaps this is the most important thing. There's no proof that IgA nephropathy is a single disease, and there's no proof it's the same disease in all parts of the world. And that's really important when we start looking at the literature. Because when you start looking at the literature and you take data that's predominantly from Caucasian Western populations, you will look at that in South Asia and India and think, well, that's not the patients I see. That really doesn't reflect my clinical practice. And actually, we need to actually accept the diversity of the disease and not just assume that what we see in one particular population must be true in all populations. And that's really important. We've already had a discussion about biomarkers. The biomarkers that may be useful to monitor disease in a Caucasian population may be very, very different to the biomarkers that we might want to look at in a South Asian or East Asian population. And again, the response to treatment may be different. So I think we need to accept and embrace these differences and think about what's right for our relevant population. And so just coming to what we understand as the pathogenesis of the disease. So central to the disease is the formation of circulating IgA-containing immune complexes. And these immune complexes have the predisposition to deposit within the glomeruli and trigger inflammation and scarring. And we think that the main substrate for these immune complexes is the presence in the bloodstream of this particular form of IgA, this poorly galactosylated polymeric IgA1 that a lot of people call Gd-IgA1. And we think that this type of IgA is derived from the B cells within the mucosal immune system. So the immune system that lines our respiratory tract, our gastrointestinal tract, our genitourinary tract. The formation of these immune complexes is not completely understood. We think there may well be these autoantibodies that recognize the IgA1 hinge region sugars and therefore promote immune complexes. But really, that's not been well understood. And actually, if you look at the levels of these IgG autoantibodies in different populations around the world, you will find very, very different data. In some populations, they seem to be important. In other populations, they're less important. So just remember that there is no one size fits all when we talk about the pathogenesis here. And the genetic data would tell us that there are genetic risk factors for developing IgA nephropathy. And separately, there are genetic factors that determine whether you are likely to progress if you have IgA nephropathy. So there are two different sets of genetic factors coming into play here, those that promote the development of the disease and those that actually promote progressive kidney function decline. When we think about what happens when these immune complexes deposit in the glomerular mesangium, we know that there's a response by the mesangial cells because they proliferate. We know these proliferating mesangial cells produce inflammatory mediators, and we know that these mediators can recruit into the glomerulus inflammatory cells, particularly monocyte macrophages, and that if that's left uncontrolled, you can get formation of crescents and necrosis. In my practice, that's very rare, but as we've heard, in other parts of the world, particularly in East and Southeast Asia, this is a far more common presentation at the time of biopsy than we see in Caucasian populations. You will also note that these inflammatory profibrotic mediators can cross the glomerular basement membrane and then come into contact with podocytes and tubular epithelial cells. And here, these factors can alter those cells and can cause injury. And what we're also starting to understand is that these immune complexes not only deposit within the mesangium, but also cross the glomerular basement membrane, particularly when it's damaged, and can also interact with podocytes and tubular epithelial cells and cause injury. And so what you see from all the laboratory work we've done in terms of growing kidney cells in the lab and experimental animal studies is the major processes all map to those features of the Oxford score. And these are features that independently are predictive of outcomes. So you have the M, E, C, S, and T scores, and they all correlate very nicely with what we found in the laboratory in terms of those changes that happen in response to IgA exposure in kidney cells. And of course, all of these processes can be amplified by activation of the complement system. And that's important when we think of new therapies. And so what I'm going to cover in my talk is a little bit about what we're starting to understand about these immune complexes, the rationale for targeting the mucosal immune system. We've already heard about budesonide. We saw that very nice talk about experience in an Indian center with budesonide. We've got how IgA nephropathy can cause kidney injury in terms of different segments of the nephron, complement activation, and then a little bit about the epigenetics and how this is starting to become a really important aspect of what we understand about what's happening in IgA nephropathy. So of course, the fundamental of IgA is, what is the IgA that sticks in the kidneys in IgA nephropathy? What do we know about it? Well, we know that it's IgA1. And you can see here a diagrammatic representation of IgA1 and IgA2. And we see that the main difference between IgA1 and IgA2 is that IgA1 has this hinge region with these O-linked sugars. We know that the IgA that deposits is high molecular weight and contains polymeric IgA. And when we talk about polymeric IgA, we're talking about IgA molecules that are covalently linked to one another with this J or joining chain. So we know that these are large, high molecular weight IgA molecules, and they're the IgA1 subclass. And what we know is that when we take this IgA out of the glomeruli, they're enriched for these sugar changes, this Gd-IgA1 that we know so well from studies in blood. But of course, what's in blood doesn't necessarily mean it's in the kidney. So it's been really important to actually take the IgA out of these deposits and see what it's like. And so we know it's IgA1, it's polymeric, and it carries these sugar changes. And if we think about the hinge region, this is the hinge region here. Here's the amino acid backbone, and here are the sugars that are attached. And you can see that you've got an N-acetyl galactosamine, and you've got potential sialic acid residues attached, and then you've got these galactose residues. And this is what we see in healthy people. And in IgA nephropathy, what we have is a loss of those galactose residues. So you've now got far more exposed N-acetyl galactosamines. Now, this doesn't sound particularly exciting, you know, just losing a few sugar molecules. Why should that cause a kidney disease that puts people on dialysis? Well, the important thing is that these sugars are at a very critical part of the molecule, and they can influence the three-dimensional shape of the IgA1 molecule, altering the relationship between these FAB arms and the FC. And of course, the shape of proteins determines how they interact with receptors, how they interact with other proteins, and actually the biological function of the immunoglobulin. And so when we look at all the data that's available, we know that if you alter the glycosylation of the IgA molecule, it will alter its ability to interact with IgA receptors on mesangial cells. It will cause mesangial cells to proliferate. It has an impact on how that IgA activates complement. And we know from observational studies that these types of IgA molecules are associated with more inflammatory changes in the kidney biopsy. So we know there's a relationship here between those sugars on the hinge region and the function of the IgA molecule in IgA nephropathy. We also know that it's these changes that can drive the formation of these IgG and IgA antibodies that recognize the IgA molecule. And so one of the things we've been interested in is looking at how these changes in sugars alter the three-dimensional shape of the IgA molecule. And so this is data on just monomeric, so single molecules of IgA1, which is really hard to study. So we performed X-ray and neutron scattering to be able to produce a three-dimensional model of monomeric IgA. And we're just about to publish the three-dimensional shape of these polymeric IgA molecules that deposit in the glomeruli in IgA nephropathy, showing the impact of changes in these hinge sugars and how the three-dimensional structure of the IgA molecule changes, and how that might explain why this IgA interacts in a different way with different receptors, and why it's causing mesangial cells to behave so differently. What we also know is all the enzymes that are important in putting the sugars onto the IgA1 hinge region. We know the enzymes that are important in putting the GalNAc on, we know the enzymes that are important in putting the galactose on, and the enzymes important in putting the sialic acids on. And actually what we know when we culture cells in the laboratory is we can alter how the IgA1 molecule is glycosylated by altering the microenvironment, by altering the chemicals that those B cells are exposed to. And this is important in respect to some of the inhibitors we're using at the moment, the drugs targeting particularly the BAF and APRIL axis. And I know Vistera have run their study in India, and they're going to be running their phase 3 study as well. But there's a lot of evidence that we can alter how an IgA molecule is glycosylated and make it more or less pathogenic by altering the cytokines and the growth factors that are in the environment of those B cells. And this is important when we think about the pathogenesis. And we published this quantitative trait genome-wide association study where we identified the genetic locus that determines the amount of Gd-IgA1 that is in the bloodstream. And it's actually in the enzyme, the critical enzyme, that puts the galactose residues onto the IgA1 hinge region. And what's important is that these single nucleotide polymorphisms, this genetic link, is in part of the gene that's all about regulating the expression of the protein. And that fits quite nicely with the fact that if you alter the environment these B cells are sat in, that it's triggered through how those B cells respond to that. And that's where we identified those genetic loci. But what's really interesting, this comes to Sasina's data that she talked about in terms of Gd-IgA1, is if you look here, we've got UK patients. So UK IgA nephropathy patients have high levels of Gd-IgA1, higher than UK healthy people. But let's compare to Chinese patients. So Chinese patients, China has far more IgA nephropathy than the UK, And if you get IgA nephropathy in China, you have a much worse outcome. But actually what we found was that patients with IgA nephropathy in China had lower levels of Gd-IgA1 than healthy people in the UK, despite the UK having very low levels of IgA nephropathy, and actually IgA nephropathy that is far less aggressive. But of course, Chinese patients did have higher levels of Gd-IgA1 than healthy subjects. And so it's not as straightforward in terms of the Gd-IgA1 story, and Gd-IgA1 may have different implications in different populations. And in fact, when we looked at the frequency of these risk alleles within the gene for C1-GALT1, they are 10 times less common in Chinese patients, which all fits. But what I want you to take from this is it's not as straightforward as just saying Gd-IgA1 is the cause of IgA nephropathy. It's likely to have a role, but it may have a different role in different parts of the world. And if you draw your mind back to Cecina's data, that was quite similar here in that UK patients had higher levels of Gd-IgA1 than Indian patients. But Indian patients, you get far more IgA nephropathy in India, and it's far more aggressive than the type of IgA we see. So again, there are subtleties here. We just need to be cautious of if we're thinking about using Gd-IgA1 as a biomarker. And again, this is data from kidney biopsy series, looking at lesions within the kidney. So here we've got a cohort from Japan, a cohort from China, and a European cohort. And it would be nice if I could add to this table Cecina's cohort, which would look very different again in terms of the biopsy features at the time of diagnosis. So you will notice the European cohort is very uninflammatory. You know, very few patients have E lesions, very few patients have crescents. You come across to East Asia here, look at the proportion of patients that have crescents on a diagnostic biopsy here. You know, almost half here, almost 2/3 here. Look at the E1 lesions, far more common in Tokyo. So again, the pattern of biopsies is very different, suggesting the inflammatory phenotype of this disease is varying in different parts of the world. And we really don't have an understanding about that at the moment. And I'm just going to finish off with the immune complexes, is that you may well think immune complexes are just IgA or Gd-IgA1 with the antibody connected together, and that's what comprises the immune complex. But actually immune complexes are far more complex than that. And actually these complexes contain a whole series of proteins, many of which could be pathogenic. And indeed, we've had some studies out of China that have looked, they've purified the IgA and they performed mass spectrometry, and they've started realizing that actually these immune complexes contain lots of different proteins that could be just as important as the IgA molecule. And indeed, this is work that we've done. And in fact, we've been presenting work where we've looked at the IgA within individual patients, and we've separated that IgA out, and we found that the fractions of IgA that cause mesangial cells to proliferate have different proteins in the complexes than the fractions of IgA that don't do anything to mesangial cells. So within our patients, we're going to have to start thinking a little bit more extensive about what those immune complexes are, because I think the IgA and the IgG may be important, but actually the other proteins may be even more important. They may be good biomarkers for the future, but they may also suggest to us new therapeutic targets. So I think if you're interested in this area, this is something to really watch out for, because with the advances in mass spectrometry, we're going to start really being able to understand what is it that's in these immune complexes. And it could be that the IgA and IgG are simply a carrier protein that takes the really interesting proteins from the circulation into and deposits them in the glomerulus. But we'll have to wait for further data to confirm that. What we presented in Paris a couple of weeks ago was data on Nefecon, so the targeted budesonide. And what we were able to show for the very first time is that you can give a treatment and it can alter the proteins that are stuck within the immune complexes. So not just looking at Gd-IgA1, but actually what are the proteins within this immune complex? And so we purified the immune complexes from treated and untreated patients before they got the drug and after they'd had the drug, and we performed mass spectrometry on those immune complexes, and we found really significant changes in the panel of proteins stuck to those immune complexes, all with potentially really important pro-inflammatory, pro-fibrotic roles. So we may be moving a step further and saying, let's not just measure the absolute level of Gd-IgA1 or the level of immune complex. Let's really drill down and find out what have we got in those complexes that these drugs are altering. So I think this, again, as I say, it's going to be a very exciting area going forwards. So if we now think about mucosal immunity, we've all seen patients, I'm sure, who have histories of macroscopic hematuria in association with infection, although from Cecina's data, it wasn't very common, it has to be said. Now, whether that's because it happened a long time ago and patients are presenting late and have forgotten, or whether it really is a difference in an Indian cohort, I think that's really fascinating and something that's worth exploring further. One of the things we're really interested in is using secretory IgA as a marker of mucosal activation. And there's lots of evidence you can see here that secretory IgA is exclusively produced at mucosal immune sites and is therefore a good marker of mucosal IgA activity. And you can see there's evidence that the levels are increased, you find it in the kidneys, and it goes up during mucosal immunization. And we have seen elevated levels of secretory IgA in our cohorts, and Cecina found the same in her South Asian cohort, again suggesting the mucosal immune system is likely to be subtly dysregulated, both in Indian patients, but also in Caucasians. We've identified lots of raised antibodies against things we would see in the mucosal surface, so Helicobacter pylori or vaccines or proteins that we might eat and come across. And indeed, we've looked in great detail, and what we found is that the type of IgA response you produce against an antigen you see at the mucosa is identical to the IgA that you see deposited in the kidneys. So an IgA antibody against Helicobacter pylori, for instance, is polymeric, it's IgA1, and it carries all those sugar changes that we see as exactly the IgA that's deposited in the kidneys. And so this is why we're thinking the mucosal immune system is the source of this pathogenic IgA. And when we look at the genetic studies and these large genome-wide association studies, and we look at what all of these genetic factors, which pathways these genetic factors are involved in, you can see here the most important pathway that's identified from all of these genetic studies is the intestinal immune network for IgA production. Again, supporting this idea that IgA nephropathy actually may, while it is a disease of the kidney, it may be caused by a disease affecting the gut or other mucosal sites. And what's really fascinating about this data is that the genetic risk was correlated with worldwide pathogen diversity. And so I want to put something to you. One of the thoughts I have is that during evolution, the mucosal immune system has evolved in different parts of the world to deal with the prevalent pathogens that we see. Now, the prevalent pathogens in India and other areas of Asia are very, very different to the pathogens we see in the UK and other parts of the world. But it may be that the mucosal immune system has evolved in such a way that protects you against short-term infections with pathogens that are endemic within India. But as a consequence of that improved protection, you're at risk of more chronic long-term IgA nephropathy because the mucosal immune system is somehow more responsive and more sensitive to challenge. Whereas in Caucasian populations where the pathogens are slightly different, there hasn't been a pressure to evolve in that way, and therefore we are less likely to develop IgA nephropathy because we need a less sophisticated mucosal immune system. So this is something that's really interesting and something that we're trying to work on in our lab at the moment. So there's been a lot of focus on the mucosal lymphoid tissue because clearly this, we believe, is the site of pathogenic IgA production. When we think about IgA production, we think about B cells, we need to understand those factors that promote B cell survival, that promote IgA class switch recombination and the production of IgA antibodies. And the two of the most important are BAFF, or is also known as BLyS, and APRIL, and they act through these cell surface receptors. And you'll already be aware that there are trials out there looking at inhibitors of BAFF and APRIL in IgA nephropathy. And some of those trials are recruiting in India, and I'm sure you will have more trials open up that are looking at this pathway. And the reason we're looking at this pathway is there's a lot of basic science evidence that they're important. So in this model of a mouse model where there is a transgenic mouse that's been designed to overexpress BAFF, quite unexpectedly, this BAFF transgenic mouse developed IgA nephropathy. And it developed it because there was proliferation of IgA producing cells in the gut mucosa. So this wasn't what they were expecting when they did this experiment, but they found that actually BAFF was really important in driving immune cells in the intestine to produce IgA. And if it was unregulated, these mice developed IgA nephropathy. And indeed, we can see from other data that BAFF and APRIL are really important in determining the response within the mucosal immune system to IgA, to naive B cells, class switching and becoming IgA secreting B cells. And what's really fascinating is that the gut bacteria are capable of influencing this process. So your gut bacteria are continually fighting against the mucosal immune system to get past the mucosal immune system, and particularly IgA, so that they can live in your gut and potentially even invade your gut. And what the bacteria are doing are producing factors to try and beat the mucosal immune system. And they can do that by communicating across the mucosa to try and alter the amount of IgA that's produced. And so we've got this continual tension. The bacteria in your gut are trying to do battle with your mucosal immune system, and the two are fighting against one another to try and maintain a healthy balance and not make us prone to infections or any particular bowel pathology. What's interesting about the BAFF transgenic mouse is that if you reared this mouse with no gut microbiome, they didn't develop IgA nephropathy. Again, reinforcing the importance of the microbiome in your gut playing a role in the development and the function of your mucosal immune system. And this is believed to be happening through pattern recognition receptors like toll-like receptors, which you can see are expressed both on epithelial cells within the gut, but also on immune cells. And these two papers are really fascinating because what this shows is that the products from these bacteria can not only influence how much IgA these mucosal cells are producing, but they can also modify the expression of the enzymes that put IgA on the IgA1 hinge region. So what this is starting to suggest is that the gut microbiome may be responsible for your Gd-IgA1 because the gut bacteria are sending signals to the mucosal immune cells and saying, reduce the amount of sugar at the hinge region. And the reason they're doing that is because these bacteria generate enzymes called IgA1 proteases that are capable of digesting the IgA molecule at the hinge region. And if there are no sugars at the hinge region, those enzymes can get in and digest the IgA much better. So what we might be seeing is that actually the type of Gd-IgA1 we're seeing in the bloodstream from the mucosa is at least in part influenced by the bacteria we have in our gut. And that bacteria is deliberately trying to generate Gd-IgA1 because it's more susceptible to digestion by the proteases that it produces. And of course, part and parcel of this signaling process is BAFF and APRIL, and that's where it's potentially exciting to see what these BAFF and APRIL drugs might do. And of course, the next obvious suggestion is there evidence the microbiome is different in patients with IgA nephropathy? And we're only just starting to see that in these studies. And there does seem to be differences in the microbiome, but we need to do a lot more work there. In a different animal model that develops IgA nephropathy, if you give that animal antibiotics and wipe out all the bacteria, it no longer develops IgA nephropathy. But clearly we can't treat patients with broad spectrum antibiotics because of the risk of antimicrobial resistance. One of the studies we are doing is we are going to give patients with IgA nephropathy a very particular probiotic. And we're going to do that to see if we can alter the gut microbiome for a short period of time and see whether that's going to change the Gd-IgA1 in the bloodstream and see whether it alters the amount of immune complexes in the bloodstream. Because if we do that, we'll be able to prove that there's a connection between the type of bacteria in the gut and the type of IgA that the kidney sees in the bloodstream. So hopefully next time I talk to you, I'll be able to give you some early results from that study. But we're now at a point where we've got those genetic risk factors that seem to be more common in East and Southeast Asia. And we now have this idea that the microbiome and the pathogens that we are seeing in different types of parts of the world could also be influencing the mucosal immune system to generate those IgA molecules that deposit in the kidneys. And so this opens up a whole new possibility for therapeutics around modifying the gut microbiome and how this might be impacted by pollution, by diet, and by other factors that we really are only just starting to understand. And so coming on now to processes of kidney injury. I've shown you this already. There are clearly very, very different patterns of kidney injury in response to IgA deposition in different parts of the world. And we really don't understand that, but we really need to try and understand that because that's going to really flavor the types of treatments we want to give our patients. The first thing I want to talk about is the inflammatory cell infiltrate. So we know the E lesion is about macrophages coming into the glomerulus, and we know from the studies that this lesion is responsive, likely to immunosuppression, and if we can reverse it, patients have a better outcome. So understanding what is going on here may well give us really good ideas about how to treat this disease. And so I'm just going to show you some very early data on a new technique that has just come out, which is something called digital spatial transcriptomics. So what you can see here is a kidney biopsy core from one of my patients, and we've stained this with fluorescent probes. And if you look over at this panel here, so it's been stained for endothelial cells. So they're in red. So you can see here some nice endothelial staining of some blood vessels. And you can see endothelial staining of the glomerular capillaries. And we've stained the macrophages with a CD68 marker in yellow. So you can see in this glomerulus here, the endothelial cells and the macrophages. And then what this technique allows us to do is it allows us to separate out those cell types. So here you've just got the image of the endothelial cells within a glomerulus. And here in that same glomerulus, you can see the macrophages that are in the glomerular capillary loops. And what digital spatial transcriptomics allows us to do is it allows us to look at the pattern of mRNA expression in those two cell types completely independent of one another. So we can start seeing what genes are being expressed in the endothelial cells and what genes are being expressed in the macrophages, even though these macrophages are lying within capillary loops very close to the endothelial cells. We can do the same for other kidney cell types, and I've just shown here, this is a podocyte stain. So we can do exactly the same, saying, okay, let's see what genes are being expressed in podocytes compared to other cells within the kidney. And so this is just some data here, looking at whether our staining has identified patterns of genes that would be consistent with endothelial cells and macrophages. And this is called a volcano plot. And what you see here are genes that have been expressed within those cells that we've marked as endothelial cells, and those genes that are expressed in macrophages. And you can see a complete separation in terms of the patterns of genes in macrophages compared to endothelial cells, which is fantastic. So we are separating the genetic profile of macrophages from endothelial cells within glomeruli. What we've gone on to look at is if you take a glomerulus that has macrophages in, do the endothelial cells look any different to glomeruli where there are no macrophages? And here is what our provisional data from one of those experiments, and they look completely different. So what you can see here is that on the right-hand side here, you can see endothelial cells where there are macrophages in the glomerular capillary loops. And you can see a pattern of genes being expressed that are very, very different to endothelial cells where there are no macrophages. And we're so so we're now able to get down to individual cell types within kidney tissue and see what patterns of genes are being expressed. And we're using this to identify pathways that are activated in IgA nephropathy, because this can tell us of potential new targets for new therapies. So what you will see coming from, certainly from the work that we're doing in Leicester, is we're going to start doing a lot more of this type of work, which will allow us to say within glomeruli, this is what's happening in the endothelial cells, this is what's happening in the podocytes, this is what's happening in the macrophages, and really start teasing out what is going on in kidney disease. You'll all be aware of the single cell work. The problem with single cell work is you have to solubilize and generate single cell suspension, and you get no idea of the interrelationship between the cells that you're looking at. Here, this is a paraffin fixed section. I think this was from a biopsy 5 years ago, just sat gathering dust in the lab. And you think about the number of kidney biopsies there are around the world that are in paraffin blocks that are just untouched, where we now have technology to be able to look at this. I mean, wouldn't it be fantastic if we were to look at this, take a cohort of Indian patients, a cohort of Caucasian patients, and start looking at what's different going on in endothelial cells in these. We could go to that level of detail now, starting to think about the differences in those kidney biopsies. And this is something that we're just starting to develop, and is a technology that's only just available. Very few studies have been done in kidney tissue, but this is where we are in terms of thinking about this. The other thing we've been interested in is the tubular interstitium. It seems to get forgotten in IgA nephropathy because we're focused on the glomerulus. But of course, we know that the tubular interstitial and scarring is what puts people on dialysis eventually, for sure. And so this is some work that we did in rats. These are rats that have been anesthetized, they're alive, they have glomeruli that sit very close to the surface of the kidneys. And so you can dissect and have the kidney on display under a 2-photon microscope, and you can inject IgA and you can watch what happens. So in this animal, we've outlined the glomerular capillaries in green here, and we've injected IgA that's labeled with a red dye. And what you can see is that this IgA is capable of getting across the glomerular basement membrane and into the tubule, and these are proximal tubular epithelial cells that have avidly taken up that IgA that we've just injected. And you can start seeing mesangial accumulation here. And you can see much more at 24 hours. Here's those IgA deposits we start seeing in our patients, but this is after we've injected it and real time watched what happened. And so we're starting to use these models to understand what IgA does to the rest of the nephron, because that's something that we really don't understand, and it may offer us new targets. And we know if we expose tubular epithelial cells to IgA in culture, they become pro-inflammatory, they become pro-fibrotic. And so this is another area where we may be able to intervene therapeutically. Again, thinking about this work, we're very interested in what macrophages do in the kidneys. And this work looked at collecting duct epithelial cells, so a different part of the nephron. You can see here macrophages stained for CD68, and you can see there's lots of macrophages here interacting with the epithelial cells of the nephron, both from the inside, from the luminal aspect, but also from the tubular interstitial aspect. And what we've done is, if you expose these macrophages to IgA and then look at how that impacts on tubular cells, these tubular cells go absolutely wild. If they're exposed to these macrophages that have been primed with IgA, they start becoming incredibly pro-fibrotic and pro-inflammatory, as you can see here, in terms of a variety of mediators, IL-6, IL-8, suggesting this interaction between inflammatory cells in the kidney interstitium. It can be driving scarring in the tubular interstitium. And this is something that we found really fascinating, and something that we are studying more and more, and is actually coming out as a new therapeutic, is the concept of exosomes. So exosomes are little blebs of the cell surface membrane that contain some of the proteins that were on the cell surface membrane, but also contain some of the proteins that were inside the cell, but also some of the RNA and some of the microRNAs that were in that cell. And these exosomes shuttle between cells, and they're a way of cells communicating with one another. And they can communicate with one another at a short distance or at a long distance. And you can see here these exosomes being generated, being recognized by a target cell, endocytosed, and then they release their cargo into the cell. And so when we performed these experiments, we generated exosomes from these macrophages, and we exposed tubular epithelial cells to them, and they caused a massive inflammatory response in those epithelial cells. So these exosomes are clearly one way in which information has been passed from cell to cell within the kidney. And actually, one of the things that is important there are these microRNAs. I'll talk a little bit more about these at the end of my lecture. But what these exosomes contain are these microRNAs, which essentially silence genes. They bind to mRNA and stop that mRNA being translated into protein. And you can see here these exosomes contained microRNAs that were able to cause these epithelial cells to transform. And we could block that effect by using something called an antagomer, which is an inhibitor, or an agomer, where we actually gave the cells excess of these particular microRNAs. With the advancing in omics, we've also been able to look in urine and identify lots of new biomarkers. I know there's been lots of discussion about biomarkers. At the moment, we don't have ones that can come into clinical practice, but we've identified a whole series of biomarkers of proteins that are important in driving scarring in the interstitium. And I just want to focus, I hope you can see my mouse, on this middle panel at the bottom row. And this is a really beautiful picture. This is stained for a protein called ADAMTS5. And these are cells, and you can see these cells just nibbling the basement membrane, the collagen in the basement membrane of this tubule. And so these are interstitial macrophages that are eating away at tubules, and they're eating away because they contain this ADAMTS metalloproteinase. And the reason I bring this paper up is because there is an inhibitor to this metalloproteinase that has actually been used in clinical trials in humans. And we are wondering whether this could be a new way to treat that inflammation within the interstitium in IgA nephropathy. And so this again is an exciting area that we think might be important. And just bringing us full circle now back to BAFF and APRIL, we also know that there are lots of cells in the kidney. We really don't understand what they do. And we have lots of B cells in the kidneys that we really don't know what their function is. But actually, we identified some proteins related to B cells in the urine. And if you look here, we can see that we've got BAFF and BCMA and TACI, those cell surface receptors, in high amounts within the urine in patients with IgA nephropathy. And it may be these BAFF and APRIL inhibitors may not only block the production of pathogenic IgA, but they may also stop the activity of B cells that are sat in the kidneys. Because we think B cells that are sat in the kidneys are releasing a lot of cytokines that are promoting scarring. And so it may be that the BAFF and APRIL inhibitors have a dual effect, blocking the production of pathogenic IgA, but also stopping the activity of these B cells that sit within the kidneys. So coming finally now to complement activation, we know complement activation has been important since really the very first description of IgA. And in terms of the complement pathways, we know it's not classical pathway driven from the data we have, but we see lots of evidence of complement activation, and the more complement activation we see, the worse the outcome for our patients. And that's been shown from multiple levels using multiple different methodologies. The more C3 we see in the kidneys, the worse the disease. And you can see this here in this really nice paper from Nick Majorel-Thomas. Here you can see progressive patients have far more C3 fragments, far more C4D, far more terminal complement proteins than those patients who have stable disease. We know the lectin pathway is important, and we know the more lectin pathway activation you have, the worse your outcome. And we know that there's a drug now, narsoplimab, that targets MASP2. And I think there are centers in India just about to open up with the Artemis IgAN study, which is a study of a monoclonal antibody that specifically targets MASP2. So you can see here a kidney biopsy is looking at all those components of the lectin pathway, particularly C4D. And so we now have the opportunity to block lectin pathway activation, and it will be great to see Indian patients coming into this study. We also know that the kind of sugars that are attached to the IgA molecule are very closely related to the C4D deposit, extent of C4D deposits we see in the kidneys, again associated with lectin pathway activation. But it's not just lectin pathway, it's alternative pathway. Lots of evidence again that the alternative pathway is important and driving disease. And again, particularly the regulators of the alternative pathway. So factor H turns alternative pathway off, and these FHR1 and FHR5 proteins stop factor H from doing that, so make the alternative pathway more active. And you can see clear relationships with the risk of progression here. And we have inhibitors now to the alternative pathway, and I believe the Applause study of iptacopan is also in India recruiting. So again, it's going to be really fantastic to get Indian patients into these studies, so we can then start in, if we have enough, to be able to look at responses across Indian, South Asian, East Asian, Caucasian patients, to be able to see whether responses are the same. Of course, we mustn't forget the kidney cells themselves can produce complement proteins, and we're really not quite sure what that contribution is at the moment, but again, a fascinating area of research. And my final section is on epigenetics, which, as I'm sure you all know, is the process by which we modify the expression of a gene without altering the fundamental DNA structure. And actually what I'm going to talk about here are microRNAs, which are small non-coding RNAs, which essentially silence genes. They bind to and block mRNA being translated through to protein. And we know from lots of studies that there are microRNAs that are changed in the kidney in IgA nephropathy, in a variety of different cell types. And indeed, we've performed next generation sequencing on kidney tissue and identified certain patterns of microRNAs that are associated with the risk of progressive disease in IgA nephropathy. And again, interestingly, these microRNAs are associated with the cells infiltrating the kidney, the lymphocytes and the macrophages specifically. This was a study we did with Chinese collaborators, and they'd started off thinking about diabetic nephropathy. So they knocked out this particular microRNA, and they found it developed IgA nephropathy completely out of the blue. And it developed IgA nephropathy because of overproduction of IgA within the mucosal immune system. So again, this shows you how complex the development of this disease is going to be. Not only is it to do with the immune cells, the interaction with the gut bacteria, the basic genetics of the disease, but also the epigenetic regulation of that. And we're only just scratching the iceberg of this at the moment. We know microRNAs can be involved in controlling the glycosyl transferases in terms of altering the level of those enzymes that put the sugars on the IgA1 hinge region. And then we also know that these microRNAs are shed into the urine and are present in exosomes and may well be interacting with epithelial cells and altering that tubular interstitial inflammation. We've talked a lot about risk prediction. We've got the International IgA Nephropathy Risk Prediction Tool. It's a good starting point, but we can get it better. And we looked at adding these microRNAs into the risk prediction tool as novel biomarkers. And we showed that we could improve the prognostic precision by adding in the measurement of these microRNAs. Now, this needs to be validated, but it shows you that if we have these new biomarkers, we can add them in to this risk prediction model and see if it improves accuracy, so that we can work out whether the value of adding these new things that we're measuring will improve how we look after patients. And now we move on to the era of RNA interfering therapeutics, which sounds science fiction, but is in fact here and now. We showed and presented data at the ERA that actually giving budesonide alters the patterns of microRNAs in the circulation in IgA nephropathy. And so we now need to start thinking, what are these therapies doing to the epigenetics in a patient? If they're altering the microRNAs, what does that mean for the genes that are being dysregulated within the kidneys, the silencing that might happen? And so again, another layer of complexity we need to start thinking about, but really exciting. And we have these therapies in IgA nephropathy. We have a silencing RNA that has been evaluated in IgA nephropathy, and this is data from 2 days ago, in fact, yesterday. The first report of cemdisiran, which is a silencing RNA against C5. We were involved in the study, and I'm part of the steering committee, and this is the first time a molecular approach has been used to treat IgA. And this is a silencing RNA that works very similar to a microRNA and blocks mRNA for C5 and stops the production of C5 in the liver. And it's been shown to be protective and reduce proteinuria in IgA nephropathy. So we have moved from having no drugs, apart from steroids and RAS inhibitors, to now having silencing RNA therapy, along with monoclonal biologics, small molecules. And it's a really, really exciting time. And I think it's fantastic that Indian investigators are involved in these studies and that we are going to get data that is relevant to all populations of patients with IgA nephropathy. We could go on for hours about the new therapies that are coming out. I'm going to stop here, but I hope you found it interesting. I'm happy to take questions, but I think, you know, we are in the golden age of IgA nephropathy. I personally am hanging on with my fingertips to try and keep up with everything that is happening, because things are happening so fast. So thanks very much for listening, and please, happy to answer any questions.
So I would like to ask you one question. Since you're saying that there is a difference in the presentation in the Asian population and in the Caucasian population, you might be having patients in your trials who are having Asian ethnicity or second generation Asian. How do they behave? Do they behave like Caucasians, or do they behave like the Asian population? I mean, any robust data on that?
So certainly the data, the best data has come out of Canada, where they've looked at their population. They've looked at patients of Pacific Asian origin, because I think they're certainly around Toronto, there are a large Filipino population. And they've looked at the outcomes in the Pacific Asian population compared to the Caucasian population, all managed with the same medications, same access to healthcare, same drugs available, same treatment algorithms. And the patients of Pacific Asian origin living in and around Toronto did worse.
Okay.
They hadn't adopted, they still kept their high risk profile. And if I talk to colleagues who have high levels of South Asian or Pacific Asian populations in their nephrology practice, they are the patients who always do worse with IgA nephropathy, even if they're living and may or may not have adopted a Western lifestyle, but they are maintaining that high risk profile.
Okay, so that shows that probably genetics is more important than environmental effects.
Well, you might think, but how? But again, you know, people do keep their dietary. They still may eat differently. You know, hopefully they haven't all adopted the Big Mac. Let's have lots of, you know, it's big steaks and beef burgers. You know, so I think genetics is undoubtedly important, but I actually believe environment is equally important here, and we really haven't teased that out yet.
Okay. Thank you, sir.
Excellent talk, Professor Barrett. I mean, you started with just GD, IgA1, and then went into complex poly IgA, then into microRNA, and then finally RNA silencing. All through the talk, I realized IgA is very, very heterogeneous. Every single presentation of yours showed that there's so much of difference in IgA. So will a single drug really help, sir, or we just have to divide IgA into its pathophysiology separately and then think of its treatments?
I think that's a really great point, Amila, and I think you're absolutely right. There is going to be no one drug that treats this disease. We are going to need I think we're going to need combinations of drugs, and the combinations will be different in different patients. And I will guarantee you that the combinations you find work best in your patients will be very different to the combinations that I find work best in my patients in Leicester. And they will be different again to the combinations that work well in China or in Japan. And I think we're going to we want to have a good panel of drugs to choose from, but I think the combinations that we're going to need are going to be very different in different populations.
So you had alluded once about Susina's work on the stool, I think, and has it ever been looked that the microbiome, gut microbiome of Asian is different from the gut microbiome from Caucasian population? Because
so in terms of just general healthy populations, there is data to suggest it's different. In IgA nephropathy, that hasn't been done, but I know Susina has a big store of feces in freezers in Vellore. I'm not sure whether she's identified that student she really doesn't like, who's going to do all the work on it. And whenever I mention it in Leicester, everyone seems to disappear out of the lab when I say, let's talk about this. But we are going to be doing that in our probiotic study. Because of bowel screening and microbiome, there's really good systems now where patients can collect their feces at home and post it in a very reliable form. It's just, we've got to identify the student who's prepared to unwrap that all and do all the studies. But I've got my eye on someone in Leicester at the moment, but we are going to be doing that. And I think it's going to be.
It looks like you're going to augment the saccharolytic bacteria, isn't it? So because Yakult is a predominant, I see my husband drinking it every other day. So it's got a very high level of saccharolytic microbiome.
So we're not going to use Yakult. We've got a very specific formulation, because essentially what we want to do is spike the microbiome, you know, just give it a big hit with a particular bacteria and see if that can just nudge the IgA immune system. Because if we can show we can do that, then it's worth investing more time and effort in finding the right probiotic. So that's the plan. And we're going to be recruiting patients and doing this very much with the patients at home. So we're going to be doing everything remotely with people sending things through the post. So I'll look forward to telling you how that goes in the future.
We will hear you in India next time, sir.
Fantastic.
Thank you. Manisha?
Yeah, thank you, Dr. Bharat. I just wanted to know, there are so many therapies emerging for IgA nephropathy. So, I mean, would you see that in future? Do you foresee that we'll be using biomarker-based therapies to choose which therapy for what segment of population?
Absolutely. So every company who's doing studies at the moment has a massive biorepository of blood and urine and all sorts, because they're looking at generating companion prognostic and diagnostic markers so that you can choose which drug to give to which patient when. Because my big worry is that, you know, if we have all these very expensive treatments, I want to know very quickly whether it's working or not, because I don't want to waste a lot of money and put my patients at risk on a complement inhibitor, for instance, if it's not going to work. So we're looking for early markers of response to allow us to direct the right treatments. So I absolutely agree. We are going to need to have good biomarkers, blood, urine, potentially kidney, way we stain the kidney biopsy, to be able to direct us to the right drug, because these drugs are going to come at a cost and they're going to come with potential risks of toxicity. So we want to be making sure we're doing the safest thing for our patients.
Thank you.
There is one question from the audience. Any role of rituximab in IgA nephropathy? Abdul Hamidi is asking.
Yeah, so the study that's been done in rituximab was very disappointing. So you got peripheral CD20 depletion, just as you do when you give rituximab to anyone, but it had no effect on Gd-IgA1, no effect on the autoantibodies, and no effect on proteinuria. So, and we know that there are certain B cell populations that are resistant to a CD20 approach. What's really exciting is that the BAFF and APRIL inhibitors seem to be able to get to the pathogenic B cells in IgA nephropathy, because we're seeing really nice responses that we didn't see with rituximab. So it's undoubtedly a B cell approach is going to be a useful one, but not using rituximab.
Should we be considering the ones which we are using in SLE now, the BAFF/APRIL inhibitors, BLISS?
Yep, so Benlysta, so the BAFF inhibitor, we're just about to start a small study of belimumab in IgA nephropathy. The atacicept study is a combined BAFF and APRIL inhibitor that is being evaluated in IgA, and there's going to be a lupus global study of that shortly. The two APRIL inhibitors are just being trialed in IgA at the moment, but Camilla, I guarantee you they'll move into lupus at some point.
We will thank Dr. Barrett for his excellent presentation, and I know, sir, you are off UK Kidney Week and spending time with us. So thank you very much for your time to us, sir.
It's always a pleasure. Always. There's just such a shame I can't enjoy your wonderful food and hospitality now, but I'll think about it as I'm tucking into my very poor English curry tonight for dinner.
We'll invite you, sir, very soon, sir.
So I think with that, we can end this session. It has been a good brainstorming session for us, and a special thanks to all our speakers and chairpersons, and a very special thanks to Dr. Jonathan for spending so much time with us. Thank you.
It's been a pleasure. Bye-bye.
Bye.